Hi everyone, it's Donna from Lymphoma Australia, and I'm joined today by Dr. Jason Butler from Brisbane, who is going to be answering a few of those COVID-19 questions that everyone has been putting through to us. I hope you're all keeping safe. Hello, Jason.
Hi, Donna, and many thanks for the opportunity to talk to everybody today. So obviously these are fairly unprecedented times. I think it's fair to say that the world's experiencing something that none of us expected would ever happen. And I think one of my patients sort of described to me that the world feels like it's been tipped upside down at the moment, and we're kind of waiting for it to tip back up the right way. So the coronavirus that we've all learned about in recent times is something of a crazy virus in that it is very highly contagious, so it spreads from person to person much more rapidly than other significant viruses like the influenza virus, so it's as contagious as a cold virus. And the other tricky thing with this particular virus is that it can cause a range of problems, from really people who have absolutely no symptoms whatsoever, so we call them asymptomatic carriers, through to people with really head cold type symptoms, more flu-like symptoms, so more significant with fevers, right through to a situation where people can get lung toxicity, pneumonias, and become very sick to the point where they need intensive care stays. Now, broadly speaking, about 80% of people will actually have either an asymptomatic or relatively mild form of the disease, up to perhaps flu-like illnesses. But about 20% of people in the broader population will have an illness that is significant enough that they may need hospitalisation. And about half of those patients will actually need intensive care to help particularly support their breathing and hopefully get them through to the point where the virus stops causing problems and they get better. Now, one of the challenges is that it can be quite unpredictable as to who gets the worst forms of this particular illness, which is called COVID-19. We do know, though, that there are some specific risk factors that increase the likelihood of a severe form of the disease. Age seems to be far and away the most important factor, and particularly people over the age of 70, and indeed people over the age of 80 seem to be at a much higher risk of a severe form of the illness. So in particular, patients over the age of 80 who get the virus have about 3/4 of those patients would actually require hospitalisation. So nearly all of them. We're starting to understand then that other factors interact with age. So other factors can increase the likelihood. We know underlying heart and lung disease are critically important, and even fairly simple things such as high blood pressure or diabetes, so illnesses that we may not regard in other situations as being risk factors for severe outcomes from a viral illness. But the other group of patients are those who have types of cancers or diseases like lymphomas or leukemias. In the relatively small number of patients that we know about in case reports that have come from overseas, it does appear that that the group of patients with underlying malignant diseases like cancers do have a higher chance of a more severe form of the disease. Because of the relatively small numbers and the fact that this virus is still quite new and we're still actually getting information fed through from other centres, it's hard to give exact information about the risks. But what we do know is that, broadly speaking, all of the different types of lymphomas and leukemias do lead to something of an increase in risk. But it appears that the group who are at most risk are people undergoing active therapy for their cancer. So if you're somebody who has a type of lymphoma going through chemotherapy, which may be something like rituximab and CHOP chemotherapy, that the risk of a severe form of COVID-19 is much higher than in somebody who had treatment 6 months ago or had treatment 5, 6, 7 years ago. So it appears to be that it's more the treatment and the effects of that treatment on the immune system that play the biggest role in potentially causing a more severe outcome. We're also perhaps understanding that the type of treatment may be important as well. some chemotherapies can have more of a role on knocking down our immune system and therefore increasing the risk for infections. And it's probably some of those more significant immune suppressing treatments that have the greatest risk. So those are treatments such as fludarabine or bendamustine. So those are treatments that do appear to have an effect on the part of the immune system that protects us against viral infections. And they're commonly used in leukemias like chronic lymphocytic leukemia and some of the low-grade lymphomas like follicular lymphoma. And then also very intensive therapies like autologous stem cell transplants and allogeneic stem cell transplants, so donor transplants. Because of the very intensive nature of those processes, and after a donor transplant, people are on immune suppressing medication to help minimise some of the complications from the transplant. But those factors then mean that your immune system is much more compromised and therefore isn't able to deal with the virus in a way that a healthier immune system can. So one of the challenges then as a doctor and other staff looking after patients with cancers is how do we best manage them in this circumstance where they have a disease that might need treatment, but at the same time a virus that could lead to very severe outcomes and even potentially death in the worst case scenario. And we're starting to understand how best to actually do that, in that patients who have diseases that are very curable, we believe those patients should always be offered the best treatment that's available at the time. And not a dose modified treatment, so not a treatment where we reduce the dose to try to minimise the toxicity, but to actually give the most appropriate treatment to give the best chance of cure. So that means in that circumstance, we would be giving patients the treatment that we would be giving them if COVID-19 wasn't around. But the circumstances get a bit trickier in diseases that are very long-lived diseases, such as follicular lymphoma, and other diseases, even in, we look after one called myeloma, for example, but even things like chronic lymphocytic leukemia, where we have treatments that are effective, but where those treatments can potentially be delayed for a period of time, and in doing so, not increase the risk of harm from the disease. So we can often delay the introduction of chemotherapy for patients with follicular lymphoma for several months, and the outcome for that patient will still be just as good after several months as it would have been if we treated it earlier on. Now, there are some circumstances where we can't delay the treatment because the person has symptoms like pain or disease that's progressing to the point where they've got larger lymph nodes or their blood counts are low. And where we believe that person would be at an increased risk from their illness if we delay treatment, then again, we wouldn't be recommending delays of treatment there. So there are circumstances where a treatment delay won't cause any problems. And at the moment, because of the risks of COVID-19 and the impact of treatment on the risk of the disease, we are recommending those patients have their treatments deferred for a short time, but under very close follow-up. But in the situations where people have a disease that we believe is very curable with standard treatments, that person should be offered that treatment. Now, are there any problems getting access to treatments at the moment? Not that I'm aware of in any of the large institutions around the country. So there's many processes that have been put into place to defer things like elective surgery, for example. And again, that's done to try to sort of reduce the workload for the hospitals in case they have patients with COVID-19 who need treatment. But those processes have been done in a way that still enables the best level of care for all patients who need treatment to receive that treatment without any compromises.
Excellent. So for patients, you were saying before, for patients who have had some medications such as bendamustine and fludarabine. So how long would their immune systems be lessened or compromised?
So generally speaking, we believe that both of those treatments would lead to problems with the immune system for about 6 months from the end of treatment. And by the end of 6 months, generally the immune system will have returned effectively back to normal. Maybe not quite back to normal, but sufficiently that we would expect them to be able to deal with infections as well as other people. So the question then can become, if I'm in the middle of treatment with one of those drugs or another type of treatment, am I best off continuing that treatment, or am I best off stopping halfway? I think most of us believe that if you actually have had treatment already started and you're in the middle of that treatment, that completing the treatment as originally planned is probably the best way to go, because there was a reason why that treatment was commenced in the first place. And rather than giving only half the treatment and therefore potentially compromising the good benefits that you can receive from that, if the decision had been made to start treatment, most of the time we'd be recommending to continue with that treatment. That's generally sort of recommended across most of the institutions that we've got.
Great, thank you. I've had a few questions about patients who have had bleomycin in the past, for instance, with or without any lung toxicities from their bleomycin. And due to the effects in the lungs for COVID-19, some patients are worried that this could be in higher risk for them as well. Is this true?
Yeah, again, I'd probably have to be honest and say none of us would truly know the actual answer to that question. I would consider that if you had bleomycin in the past and it did not cause any problems with the lungs, then we would not expect that in itself would be an increase in risk if you did get the coronavirus. However, if you had an injury to the lungs from the bleomycin, and for example, your treatment had to be dose reduced, or in fact, the bleomycin had to be stopped because of that lung injury, we do know that only some of that lung injury tends to get better. So most people who have had some side effects from bleomycin will have a degree of permanent injury to the lungs, which may not normally cause them any problems day to day. They wouldn't notice any problems with their breathing, but it would probably make them more susceptible to the risk of pneumonia from COVID-19. As I say, it's because of the very small number of patients with cancers who've had problems from COVID-19 and the relatively uncommon use of bleomycin, it would be hard to be absolutely certain about what effect it would have. It would probably be important if you were somebody who had known lung problems from bleomycin before to be especially cautious in terms of trying to avoid contacting, which is largely doing all the things that we're being told to do on the news. So keeping ourselves isolated, keeping socially distant from people, as hard as that might seem sometimes, particularly for those of us who are older, or those of us who have older parents and grandparents that we're not able to see. And most importantly, good hand hygiene is one of the critical things. So it is felt that the most common way that we actually contract the coronavirus is by contamination of our hands on something that we touch. But the virus on our hands can't actually really do anything, because it doesn't really enter our body through the pores in our skin. But in fact, the way that we do introduce
Hello? I just got a technical issue. You there, Jason? No? Oh, sorry about that. We had slight technical issue. I was just going to ask a couple last questions, Jason, and just in regards to, firstly, I'm getting a lot of questions about the flu vaccination and whether patients should be getting that, even if they're having maintenance therapies, and the pneumococcal vaccination as well. What is your opinion there?
Certainly, in terms of the flu vax, the answer is absolutely yes. In fact, even outside of the problems with COVID-19, on an annual basis, all of us should be getting the flu vaccine done, it would be fair to say. Now, in patients who are immune suppressed, the question is often asked, will the flu vax cause me problems? And the answer is no, it shouldn't. The reason being it's not a live vaccine. So the main problem with having the flu vax done whilst you're on active treatment is that that treatment may stop your immune system from responding to the vaccination properly, which means the vaccine may not work as well as it should. So it may not give you as good a protection against the flu as somebody whose immune system was normal. Now, there's a couple of things to do there. One is get everybody around you to get the flu vaccine done as well, because if your immune system doesn't get perfectly stimulated by the vaccination, if everybody around you is having the flu vax, then that will help protect you by not introducing it into the household or to workspace, for example. The second thing is there is a little bit of evidence that having the flu vaccine done maybe a second time, say 6 to 8 weeks after the original vaccination, may improve the likelihood of getting a good response to it. Now, that's not at the moment sort of an absolute recommendation, but there is some evidence to support that. And certainly some GPs would be quite happy to do that. There isn't any increased risk by doing that of getting more severe reactions. So the important thing is the flu vaccine is safe. It's because it's not a live vaccine, you absolutely cannot get the flu from the flu vax. You can get a bit achy, you can get low-grade temperature sometimes, which is simply your immune system's response to the vaccine. Now, the other important thing to mention, and this isn't a reason not to go and get the flu vax, but all the things that you will be doing to protect yourself from the coronavirus will also help protect you from getting the flu as well. So influenza is a far less hardy virus. It's far less contagious than coronavirus. So the process of washing your hands, keeping socially distant, will actually make it highly unlikely that you would get the flu whilst doing those things. But still really important, because hopefully in a few months' time we'll all be able to get back to being relatively normal again and start doing normal things. And so at that point in time, the risk of getting something like the flu will go up if you've not had the flu vaccine. So better to protect yourself now. The pneumococcal vaccine is similar in that it is not a live vaccine, so it again is safe to give. There are some specific circumstances where people definitely should get the pneumococcal vaccine, particularly those who've had really intensive treatments like transplants and that. In other people getting more standard therapies, there's a little bit more of a debate about the value of the pneumococcal vaccine. So I think talk to your haematologist or even your GP about the benefits of that. But if they've recommended getting it, then you definitely should. Again, very safe to give. But yeah, critically important. Very, very strong opinion about everybody getting the flu vaccine done.
Excellent. I've definitely booked in for mine in the next couple of weeks. Good. And just finally, a lot of patients are quite concerned about going to hospital and going for their appointments and scans, and there's been a lot of talk of maybe boycotting those. What would your advice would be for those patients?
So I think, again, there's probably some circumstances where we as doctors will defer getting scans done for a period of time, or perhaps even defer appointments in the short term in situations where we believe that no harm will come to you by doing that. However, where it's clear that your doctor still feels the need to see you or get scans done because it's important to follow up your lymphoma, or they're perhaps even concerned that something might be happening with the lymphoma, it still remains really important to do that. There are lots of contingency plans that have been put into place to minimise the likelihood of, and the number of people who you come into contact with when you go to the hospital or go to the medical imaging facility to get your scans done. So, hand hygiene is critically important. Every health institution will have instituted mechanisms by which you can maintain social distancing whilst in the clinics. That will include like removing chairs from the waiting room or or putting objects on chairs so that there will be appropriate distance between patients when in the waiting room. Most of the medical imaging places have set up arrangements where you can almost be taken in immediately to get the scan done to minimise the contact. So really, really important to continue to go to the appointments and get scans done. The other thing we're trying to do is, where possible, to do many appointments by either telehealth, which means using something similar to what we're doing here, where we can video in FaceTime, Skype, and various other technology platforms so that we can actually still see you. Or secondly, the government has also enabled us to do telephone calls to replace consultations, which have never been able to do before. And I must say, the government has been remarkable in how quickly they've introduced some new strategies to enable healthcare to be provided safely and, I believe, just as effectively as we were able to do beforehand. So that has a couple of things. So if your doctor feels that your appointment can be moved to a telephone, that will always happen. Most hospitals are now making telephone consultations the default, and it's only in circumstances where medically we believe that we need to see you face to face, which will normally be because we need to examine you, or secondly, there's really important information that we need to give you that perhaps is felt a bit difficult to give via a telephone call. So those are the only circumstances generally where we're getting people to come up. And the other obvious circumstance is for people who need to come up to actually get treatment. But because we're actually doing a lot of the visits by phone calls and telehealth, it means that our waiting rooms are much quieter. They're relatively empty. So again, it provides a very safe environment for the people who do need to come up to the hospital to actually be, have a very, very low probability of coming into contact with somebody with the virus. I think at the moment, as we record this, across Australia, we're doing very well. All of the things that we've been doing to keep ourselves safe is meaning that, we're at this point in time, we have the virus well under control. It's not gone, so we have to continue to do all the things that we're told to do. But I think there's a glimmer of hope that, at least in this country, we won't see some of the terrible things that we've seen overseas. And that again is because of all the good work that all of you are doing out there.
Excellent. Thank you. I think you answered and relieved a lot of people's minds, some of the questions. So thank you so much, Jason. And for everybody, Lymphoma Australia, we've produced some fact sheets to give you a lot of that information that we provided today. And I'll include that in the notes of the video, and you can find them on our website. And from next week, we have been playing with different media platforms such as this, and we will be doing the coffee catch-ups and support groups and education events, which I'll be advertising the next couple of days. So stay tuned, and any questions, please obviously call the Lymphoma Care Nurses, and the numbers are on our website, or email me. Okay, thank you so much, Jason, for your time.
Thanks, Donna.